It's now my pleasure to reintroduce Dr. ANDRA James. Now, she's very modest. She's saying, oh, you don't need to go through that whole thing again. And my co-chair is saying, yes, you do. And so I've decided that I will just not listen to either one of them, really, other than to tell you that when we did the WFH Congress in Bangkok, Thailand, I was asked to do a session, actually, I believe it was David Page, who asked me to do a session with ANDRA James, who was chairing the session. And what we were talking about was leadership, and mostly we were talking about leadership with women. And my topic was leadership leadership as a woman in a male-dominated organization or society. And it was fascinating, the research that we did. And then Andy and I had a lot of fun about some of the discoveries on that. But I just remember thinking, I was just almost giddy because it was ANDRA James. And I was so excited to meet her, to shake her hand, because she's been long recognized as a leader and a strong advocate for women around the world, women with bleeding disorders. So I think we're just so lucky to have her here in Canada with us today. So ANDRA, I'll let you take over. Thank you.
Thank you for that very generous and kind introduction. I've never given this talk before. I've never been asked to give this talk before, so you're going to hear it for the first time. I have many disclosures to make, none of which have anything to do with funding, and you'll hear them now. I'm going to talk to you about my career path, my personal story, and my atonement. First, the career path. You may recognize the glasses. I was wearing the same glasses, basically the same glasses in the 1970s that I'm wearing now. If you just keep them in your drawer long enough, they'll come around. But I started my career as a nurse midwife. I trained at Johns Hopkins University in Baltimore, Maryland, and I did moonlighting at Baltimore City Hospital as a labor and delivery nurse, charge nurse on labor and delivery, in fact, while I was in school. And in the summer of 1976, July of 1976, the residents admitted a patient with, quote, preeclampsia, unquote. She was about 36 weeks gestation. And one morning they brought her downstairs because she had turned yellow and her blood pressure was a little higher. So we put her on the one fetal heart rate monitor we had then. And anybody here, where is Mary Ann? Oh. We had, I don't know how many of you are familiar with fetal heart rate tracings. We weren't very familiar then, but we've since come to learn that a flat fetal heart rate tracing without periodic accelerations is potentially ominous, especially when there are repetitive dips in the fetal heart rate in response to uterine contractions. So we did recognize that the decelerations were a problem, and she went for immediate cesarean delivery. Now, because she had what was presumed to be infectious hepatitis, she was put in isolation after the delivery, while I only had one other RN on the floor with me, and I had to put the patient in isolation. The nurse was a new graduate, so I put her in the room with the patient, and I took care of all the other 6 laboring patients, several patients who were in recovery, etc. And it wasn't long after she was in the room that she came out and she said, the patient is bleeding too much. She, in fact, had said that about every single patient she had taken care of in the postpartum recovery room to that point. So I wasn't alarmed at all, and I said, I'll be there in a minute. She said, no, you have to understand this patient is bleeding entirely too much. So I went in and she had soaked through the gauze of her abdominal dressing and she had soaked through her chucks and the blood was dripping on the floor. So we got the physicians back in there. They took her to the operating room to try to deal with her massive hemorrhage. I ran down to the blood bank and got, I don't even know what I got, but it was red. I don't know if it was whole blood or packed red cells, but I brought blood back up from the blood bank for the rest of her life, which wasn't very long. So that was just after Al Killam, who ultimately became my fellowship director in maternal fetal medicine, published an article on pregnancy-induced hypertension complicated by acute liver disease and disseminated intravascular coagulation, an article I wasn't familiar with. And it was before Lou Weinstein wrote his seminal paper on HELLP syndrome. After I finished my training, I was offered a job at Baltimore City Hospital, but I went out to work at Fort Defiance Indian Hospital in Arizona. That's me doing a repair. And we had two maternal deaths from hemorrhage in the 3 years I spent at Fort Defiance Indian Hospital. One was from a ruptured ectopic pregnancy, surgical bleeding. And the other one was from placenta previa, obstetrical bleeding. And I was still haunted by that case of coagulopathy I had seen back at Baltimore City Hospital. And I tried to make it fit when Lou Weinstein published his paper on hemolysis, elevated liver enzymes, and low platelets, and from which the term HELP was coined. Al Killam should have come up with something catchier. But all of the HELP patients I took care of subsequently didn't get as yellow as the patient in Baltimore, nor were they as coagulopathic. I couldn't quite fit that together. So I wasn't satisfied that I really understood what had happened in Baltimore in 1976. But I had, by this point, learned enough about obstetrics to know that it was not normal and natural. So I went to medical school. Here I am and with my lab group at the University of Virginia. I'm the one who refuses to wear the white coat, knowing I have been wearing a white coat for years and was going to be confined to a white coat for the rest of my life. I just wore a butcher's apron. And then my husband was transferred to North Carolina, which worked very well for me because one of the top 5 OBGYN residencies in the country that time was in Chapel Hill. So I went to the University of North Carolina at Chapel Hill for my residency and was fortunate enough to be accepted there. I also learned while I was there that coagulation tubes are the color they are because, at least according to the conventional wisdom there, the color was chosen because it is Carolina blue. So during my second year of residency, we had a patient who was transferred from a hospital in Raleigh, North Carolina, about 20 miles away. Now, as a second year resident in OBGYN, my responsibility at night was to cover the patients who were admitted to the intensive care unit. Usually that was a GYN oncology patient, but it also included an occasional obstetrical disaster. So we had this patient come who was yellow, who had been diagnosed with preeclampsia during her pregnancy, and 3 days postpartum, she became very jaundiced and had very elevated liver enzymes. She was only mildly preeclamptic. She didn't particularly have low platelets. They did an ultrasound of her abdomen, didn't see any stones in her gallbladder, but made a diagnosis of acalculous cholecystitis. So she underwent emergent cholecystectomy and began to bleed. Her blood didn't coagulate. She developed multi-system organ failure. She was transferred to the University of North Carolina, and I was the OBGYN consultant while she was in the SICU. And unfortunately, she didn't live very long either. But I did learn what she had. She had what was sometimes called acute fatty liver of pregnancy, and other times called reversible liver failure of pregnancy. Not as common as HELLP syndrome, occurs in about 1 in every 5 to 10,000 deliveries, but I now understood what had happened back in Baltimore in 1976, and I also understood it was associated with blood that didn't coagulate, and that coagulopathy in this setting was a death sentence. So my fourth and final year of OBGYN residency, I was the chief resident on the OB service when these two men who I'd met before, Dr. Harold Roberts and Gil White, had a patient with factor 2, 7, 9, and 10 deficiency who Dr. Roberts had described when she was a newborn, and now she was pregnant. She lived in South Carolina, but she was going to come back to North Carolina to deliver, and my job as the chief resident on the OBGYN service was to deliver her, and my attending physician said, and you'll do that without a cesarean, without forceps, and without a vacuum. I was up for the challenge. I did learn, however, that her bleeding disorder was so profound that she only raised her factor 2, 7, 9, and 10 levels above 1% when she took supertherapeutic doses of vitamin K. And as a teenager, because teenagers are exempt from medical laws, she stopped taking her supertherapeutic doses of vitamin K. She hemorrhaged from her ovary, developed a profound retroperitoneal hemorrhage, was admitted to the intensive care unit, and required 17 units of blood. So it was a little daunting, the thought of trying to get her delivered without bleeding, and my impression of delivery in patients whose blood didn't clot was not good. So she had a 9-pound, 12-ounce baby, which I was able to get out with a Ritkins maneuver and an episiotomy. A Ritkins maneuver is a manual trick. Doesn't involve forceps or vacuum, and a small incision in her perineum. And her uterus began to contract just like it should. She did not have obstetrical bleeding from her uterus. However, she tried to exsanguinate from her episiotomy. There was no amount of pressure I could put on that perineum that would slow or stop the amount of bleeding that she had. Fortunately, Dr. Roberts and Dr. White had left a recipe for us to follow in case of this eventuality. We were supposed to start fresh frozen plasma and then initiate prothrombin complex concentrates. And after she'd gotten the first 2 and was on the 3rd unit of fresh frozen plasma, the bleeding subsided. I was able to repair her episiotomy, and she, not until later, required the prothrombin complex concentrates. Well, I thought this was magic. So I thought, gee, I at some point would like to become a magician like that. Well, I finished up my residency at North Carolina. Some were sorry to see me leave, but I was welcomed at Duke University with open arms. And during my fellowship, this is an older version of me in fellowship, I joined the lab of Dr. Russell Ware. Some of you may know Dr. Ware at Cincinnati Children's, and that is his lead technician, Dr. Thad Howard, and this is a reunion of the 3 of us at ASH. I spent 3 years in Dr. Ware's lab looking at prothrombotic disorders in fetuses who had had an in utero vascular disruption. And during that time, I developed a good working relationship with Dr. Tom Ortel. Some of you may know Tom. This is one of the nurses, Melissa Britt, who was the director of our thrombosis and hemostasis center there at Duke, an adult hematologist who's now our division director in hematology. And through the support and partnership with both the Division of Adult Hematology and Pediatric Hematology, I was able to establish a clinic for women with blood disorders and women and some girls to some extent with blood disorders there at Duke. Now onto my personal story that's woven in here. So in 1998, Dr. Ware took the entire lab to the American Society of Hematology meeting in Miami. I got the program in advance, and so did Dr. Ware, and he said, here's one I think you'll be interested in. It was a Friday morning satellite symposium featuring these experts. And the topic was women and bleeding disorders. Jean Losher has since passed away. Stephanie Ceramides is at Novo Nordisk now. You've probably met Peter Coides. You've heard Roseanne Kadir and Dr. Christine Lee quoted during this meeting. And in that meeting, I heard Dr. Lusher say that every woman with heavy menstrual bleeding or menorrhagia should be tested for an underlying bleeding disorder. Okay, I had just finished my training in obstetrics and gynecology, and I had never seen a woman with an underlying bleeding disorder unless she came pre-labeled by Dr. Roberts and Dr. White. So there was, otherwise, was entirely skeptical that this could possibly exist. But when I got back from the meeting, Dr. Ortel said, gee, I have this new platelet function analyzer. Do you see any applicability in OBGYN? I said, well, I just heard Dr. Lusher say that every woman with heavy menstrual bleeding should be tested for an underlying bleeding disorder. I suppose we could start screening women with this instrument, and then if we get some funding, we could do the requisite platelet aggregation studies and von Willebrand studies to see if indeed that was really the case, intending to prove Dr. Lusher wrong. And while we were trying to raise awareness about this study and increase enrollment, a man in our community told his wife that he thought she had that disease that we were publicizing, because in fact she had a hemorrhage after she had her von Willebrand teeth, her wisdom teeth out. She had remarkable bleeding after foot surgery. She had some unusual bleeding after delivery, and she was plagued with heavy menstrual bleeding. In fact, she was slated to have a hysterectomy. So the woman went to her gynecologist and told her that she thought she should be enrolled in this study. And as it turns out, the woman had mild von Willebrand disease and was later found to have a mild platelet dysfunction. And the irony is that this woman had come to her gynecologist, and the gynecologist had written this as the chief complaint, suggesting that there was some inherited aspect to this. And the other irony was that the gynecologist was my co-investigator in this study, Dr. Lucas. But the real irony was that the patient was myself. And I had failed to see a number of red flags in my own personal history and failed to recognize a bleeding disorder myself. It took my electrical engineer husband, who was reviewing my advertising materials for the study, for understandability for a layperson, to say, "You have that disease." But I blame my mother to some extent, because she said that that was normal in the women in our family had beefy periods. And here she is, my beloved mother, on her wedding day to my father. I lost my mother 13 years ago, but my father is still around. He's 102. And he's moving to my community next weekend, I hope. He still lives on his own. This is my mother's sister, Mary, who suffered from beefy periods as well, and had a big GI bleed that threatened her life and put her in the intensive care unit at one point in her 60s. And this is my mother's sister, Eloise, who had, quote, anemic periods. So for Dr. Schutzberg, this is normalization of bleeding symptoms. Now, so I didn't use any pictorial blood assessment charts in assessing my patients with menorrhagia during my residency. The screening I used, as if they told me what their periods were like, I would compare theirs to what mine were, and invariably, mine were heavier, so theirs must have been normal too. I also didn't use any bleeding assessment tools or BATs, despite the fact that there are a lot of BATs out there. So as a consequence of all the damage I did during my training, I have had to atone for this. I think of all the women I told with heavy menstrual bleeding that their periods were normal. And so I've embarked on a three-prong attack here. Educating consumers, doing my best to educate consumers through whatever means possible, and educating the community. Educating healthcare professionals about the unique needs of women and girls with blood disorders, and trying to inform our policymakers so that our women with bleeding disorders have advocates. So maybe some of you recognize Sally Owens Crutter McAllister here, who was at one point the acting director of the Blood Disorders Division at the Centers for Disease Control. This is myself, and this is Maggie Ragney, whom some of you know, on the piano. She wrote the song we're singing. And this is Steve Humes, who's the director of the Hemophilia Treatment Center in Chapel Hill. But Sally, recognizing my personal and professional story, nominated me for the Women's Task Force at the National Hemophilia Foundation, during which time we were developing Project Red Flag, real talk about women's bleeding disorders, an outreach program designed to educate consumers, healthcare providers, and policymakers. At that time, one of our sponsors was ZLB Behring, who was the forerunner of CSL Behring and had been the successor to Senion, who sponsored that program at Friday Satellite Symposium at ASH, where I heard Dr. Lusher. So I'll thank CSL Behring for sponsoring this program here today. They've been a good citizen in the bleeding disorders community, especially for women and girls. And we'd like to think that Project Red Flag served as a prototype for Code Rouge. So, at the suggestion of Dr. Ortel at Duke, I got involved with the International Society of Thrombosis and Hemostasis and joined the Women's Health Issues Working Group, which ultimately we were able to morph into a scientific subcommittee. And then in 2009, with my colleagues, Barb Conkle from the University of Washington and Roshni Kulkarni from Michigan State University, we organized the Foundation for Women and Girls with Blood Disorders. Our vision is that all women and adolescent girls with blood disorders are correctly diagnosed and optimally treated and managed at every life stage. And the tactic we have embraced to achieve that vision is to educate healthcare providers about the unique needs of women and girls with blood disorders, primarily educating hematologists and other people who provide care to patients with blood disorders about the unique needs of women and girls or reproductive issues, and provide obstetrician gynecologists and others who provide care to women, who provide women's health care about the unique issues associated with blood disorders and the overlap of those conditions. We now have 4 or 5 full-time staff. We've got about 10 people on our board. We're going to be at ASH this year holding a Friday satellite symposium on complement-mediated disease in women and girls. You can find us at fwgbd.org on the internet. So I hope that through this talk, you'll be able to forgive me for the damage I've done in my career and that I actually have achieved or deserve forgiveness and atonement. Thank you very much.
I just want to thank Dr. James for not only giving a fantastic presentation, but for sharing something that could only be perceived as not only personal, but obviously very emotional. It's very unusual to have the caregiver as the patient and the patient as the caregiver all in one. And I thought it was a unique opportunity to hear from that perspective, which we don't hear very often. And so thank you very much for that exhilarating talk and obviously all the issues that come out of that. And I want to open the discussion. We have time for a few questions before we have some closing remarks.
I will say that people say, well, now we know why you have chosen what you chose to do. Well, it was the other way around. The diagnosis chose me after I started my career in this direction.
So it's a bit of a comment and a question. So first of all, I wanted to say that I don't think that you have to atone for anything. No, really, because I think that we are taught about menstrual bleeding by our own experiences and the experiences of our families. And so I think that you just showed so perfectly how much our own personal experience colors the way that we see our patients and how our patients see themselves. So I see it as absolutely natural. I honestly can't say that any patient with any bleeding disorder that I've seen, or maybe like one, has told me she has heavy menstrual bleeding. They just say it's normal. And so I reframe the question. I just say, tell me about your period. And my question is, has your personal experience shaped the way that you now assess your patients, or how has it?
Yes, I am compelled now to use more objective means. And I'm excited by the work that Paul has done, Claire Phillip in the United States, to try to help women with heavy menstrual bleeding get appropriately triaged, so that the ones who should be screened, tested, and referred on to hematology get screened, tested, and referred, and those who really don't need referral are able to be managed by their OBGYN or family physicians. Thank you.
So maybe I'll ask a question. So we've heard about similar programs for advocacy and education, both for caregivers and patients in Canada. We know about the program for a long time now in the United States. We know that in the UK there's a similar program for advocacy as well. And the question is that what is the work to be done in other countries to advocate? We saw that the screening results, much like you're saying, is based on what Mom told us, what normal is. And the question is, what's our role as in the community to try to develop, maybe not the program necessarily because of resource concerns, but to get that message out and to educate, elsewhere in the world.
So I'm going to answer a little indirectly. I look back in my own career path, and I see who were the people who saved the life of the patient with factor 2, 7, 9, and 10 deficiency, and who were the people who had the knowledge and the capacity to save the 2 women who had the acute fatty liver and were coagulopathic. It was actually the experts in hemostasis who weren't available at Baltimore City Hospital and weren't available to the community in the community hospital in Raleigh. And yet, the leading cause of death in childbearing age women around the world is childbirth, and the leading cause of childbirth-related death is hemorrhage. And while heavy menstrual bleeding is rarely life-threatening, postpartum hemorrhage is, and the knowledge that is accumulated by experts in hemostasis applies to the potentially lethal condition of postpartum hemorrhage, so that we ought to be teaching, educating, and preparing experts in hemostasis around the world so that they're not only prepared to take care of the inherited bleeding disorders, but the acute acquired coagulopathy that accompanies postpartum hemorrhage. I was asked to come to a meeting of Gates Foundation investigators who were investigating postpartum hemorrhage, and I thought, I'm not involved in any studies in this worldwide. But it turns out that their preliminary data was showing that they could reduce postpartum hemorrhage in under-resourced countries, but they couldn't eliminate the final common pathway, which was coagulopathy that led to maternal death. So they were reducing the numbers of women who suffered from postpartum hemorrhage, but they weren't eliminating death from postpartum hemorrhage because the final common pathway was coagulopathy. So I think that I would, if I have a message from that, it's that those of us in the hemostasis world should think very broadly about how important this knowledge is that we have and how it can be applied more broadly to benefit our citizens in the world.
Just a comment related to that. Our colleague Eliana Seidenberg, who's not here today, has started to look at the curriculum in medical school to see if there's sufficient exposure to women and bleeding disorders in the curriculum. Now, of course, I don't have any results to share with you, and I don't know if she has them yet, but she's starting to collect data looking at the exposure in medical school, more particularly for medical school, but also later for hematology. And hoping that when you choose a path in hematology, that at least the exposure there would be sufficient to be able to train experts in this area. So that's one of the interesting projects that's going on the Canadian level right now.
Cool.
Any other remarks before we close? Thank you, Dr. G.
Thank you very much.